So, next we have a keynote on the topic Building AI powered palliative grid. And we have Dr. Athul Manuel, Medical Officer, District Palliative Care Center, Ernakulam. And we have the team Sanjay Vijayakumar, co founder of Pupilfirst, and Bodhish Thomas will be joining online, is the co founder of Open Healthcare Network.
So hi everyone, I'm Dr. Athul Joseph Manuel. So I am the odd one out today. Like we have a whole technology professionals surrounded by within me, and now we have a healthcare professional working at talking about a new playground that is coming up, which is known as the Open Healthcare Network. So I just want to show you guys what we were able to do or what we are planning to do and how we are going forward with that. So we are talking about two kinds of mindsets here when we talk about healthcare professionals and technology professionals. So this is somewhere that I want to thank FAYA in coming in, making a platform where both these mindsets can come together. And these mindsets, when I talk about two mindsets, the one is the healthcare professionals, which I represent. And what we found out was healthcare professionals are mainly unilateral thinkers. So we don't have an undo button in our whole system. So if I give a medicine to a patient, there is no way that I can take back the medicine. If there is anything to be corrected, then I have to do an additional support, another medicine to cure the whole system that was went wrong. But when you talk about healthcare professionals, there's an option where you can undo what you did, you can delete the whole thing and create another whole bunch of code. So this was a very unique thing that we found out while I started interacting with the healthcare professional system. And in this journey, we came upon was we met during the COVID times, and most of the COVID helped people to interact with their own families, but we got this opportunity to interact with the healthcare professionals and the technology perspective. And we knew right from the beginning that COVID, everything was about load management, capacity management. That is where the technology came in. Technology came in an aspect where we were able to get the whole thing done in a dashboard, which we were able to do within the whole Google Sheets and Google Forms that we're using that time. And this is when we met the Open Healthcare Network, which was known as Corona Safe back then. And then we found out that we were able to do more. Like the screen you can see is the control room that we had in our district, Ernakulam district, where I still remember initially we had the capacity management of quarantine places. Later it became capacity management in terms of ICU beds. And in the end, during this Delta wave, it was about capacity management of the whole oxygen war room that was happening. And I invite Mr. Bodhish to talk to us regarding the whole things that we were able to do in terms of Open Healthcare Network.
Hi,
Bodhish?
Vipul. Hello, I think I'm audible. So to get started, the screen that you're seeing on your on the display is a war room that was created during the pandemic. It was built on the fly with like a lot of volunteers from Kerala coming in to build each one of the systems, and the data was fundamentally generated in each independent facilities and curated into a dashboards for healthcare administration to like work with. So on the left you see like a daily dashboard, center you see the capacity monitoring, and the right side you see the oxygen dashboard and its usages. And there was also alerts, the oxygen is going to like end in this facility in the next 10 hours. So we were able to like quickly pull this up even without the age of co-pilots, with the pure community involvement. So better than me introducing, I think it will be better we hear from Satya Nadella talking about Open Healthcare Network. Can we go to the next slide? It's a small video. I hope the sound comes through.
Are you going to?
States in India, and it all was a pandemic project that's taken on the planet. That's unique to the Open Healthcare Network folks. That's a community that was born on GitHub. It's fantastic to see what they're doing, right? So they're built an open source EMR system. They even built an open source Delhi EMR system. It's just superb, and it sort of obviously composes with the rest of what's happening in India, which is so unique around these digital public goods. And in fact, they're now available in 200 plus hospitals across more than 9 states in India. And it all was a pandemic project that's just taken on a life of its own.
Next slide, please. So we got the recognition of being the 50th digital public good right after COVID. We were able to manage the wave 1, wave 2, and also deploy the system in multiple states in India. So this was like a good recognition. Like the DPJ team audited the entire software and made recognized this as the 50th digital public good in the world. And next slide. After the COVID, what we really figured out is like there is like a huge shortage of experts, doctors in the world. I mean, it's a global scenario, and in India also, Srikanth Nadamuni created a lot of 10-bed ICUs, and the adequate number of doctors to manage each of these facilities are like limited, and to build intensivist, it takes a lot of time, and that's when we decided we should like improve the EMR features in the system that we built during the pandemic to support the entire system. So we went in and like rebuild the entire EMR structure to support critical care infrastructure. So anything like from like a OP consultation till critical care, care is now enabled to support complex UIs with very seamless access. Like doctors will be able to like click and see like what's the BP, what's the condition, what medicine they have to give. We cached in all the medical record, medicines records, process data of book of medical images and books to like build out the entire open stack to like feed in the data. Next slide. We also built a lot of real-time monitoring capability. This is all in open source. So any adapter, any camera brand, anyone who wants to integrate, so they'll be able to like use our tooling and use our softwares to run system. So a hub can like act, a medical college can act as a hub that will cater to all the nearby district hospitals in providing real-time care. We also work with a lot of device integration. So basically, any device that you connect, so all 5 para monitors that a patient uses, which they'll be connected when they are admitted on an ICU, we are now able to like get the data up in the cloud and stream it to a doctor sitting remotely somewhere else and observing these patients. We also like were able to create these central nursing stations. The digital version of these are now able to like power a lot of nursing stations in 10-bed ICUs. Next slide. We also built ABDM compliance. We are ABDM 1, 2, and 3 compliant. That in a way, it's a most interoperable system, and we are a showcase piece of the ABDM story. So any data that comes into the system is now interoperable. So they'll be able to like any patient who goes to care, uh, gets care in Karnataka can now go to Manipur and then fetch the data through ABDM to get continuum of care. So it's completely integrated, and we are currently running in 9 states, powering 206 hospitals. These are all independent instances deployed and connected through ABDM for transactions. Next slide. So if you look at it, it's a span of over the span of last 50 months, we're able to like deploy it in 12 Indian states, and it's all created by 500 plus volunteers. A major chunk of the community is from Kerala, and we're able to like achieve all of this just because of the power of community. And our new need is palliative care. Dr. Athul will explain more about what we are planning to do.
So basically, me as a healthcare professional, I'm a palliative care doctor who works in palliative care for the past 10 years now. And when you talk about palliative care, it's often the moodiest part of the whole healthcare system. And we'd be wondering what the technologies have to play in a palliative care background. And we know palliative care mainly focuses on bed-bound patients. Mainly now the narrative has changed to catering to the serious health-related suffering of anyone. And when you talk about bed-bound patients, you would often think that we are too young to be thinking about bed-bound patients. So I just want to give a narrative to you where this is a data which shows that 85% of us sitting in this room will be bed-bound before we die. So there is no question that we are going to die or not. So 85% of us will be bed-bound before we die. And as the technology improves, as healthcare tech comes up, accidental deaths come down. And as accidental deaths come down and the whole lifespan or the average lifespan that we call is now 78 for females and 72 for males would go up. And as all this advancement happens, the percentage of people who are going to be bedbound will keep on increasing. So as more advanced you get, next data that comes out will be 90% of us will be bedbound. So if you take a nuclear family, which is mostly what is nowadays, out of the poor people in your family, 3.5 of you will be bedbound. That means for 100%, you will be either the person who is receiving care or you will be the person who is delivering care for your family. So this is where we are going at. This is why you as tech professionals or even just as a human being in this world need to know about palliative care, need to be part of palliative care. And how you can be part of palliative care. So just think of the need. Presently, the bedbound patient comprises of close to 0.7 percentage of our whole population, which is 2.5 bedbound patients currently in Kerala right now, right today. And people are not bedbound but are having serious health related suffering would cross about 8 lakhs, which is another 2.8 percentage of the whole population. So currently, what we are focusing is on the bedbound patients. And what has happened in the palliative care world, which is a very silent world that has grown on its own for the past 3 decades, is that right now, under the government system alone, we have more than 1,400 units delivering palliative care in Kerala right now. You give me any address of a patient who needs home care, I'll make sure that within another 5 to 8 days, the nurse reaches any home. Say any panchayat, any municipality, any corporation you take, there is a palliative care system. That is where we have reached in the past 30 years. And even in the NGO sector, which started off palliative care, we have close to more than 500 NGOs working in this sector. And how it happened, started off back in 1993 at Calicut Medical College, where the knowledge of palliative care was shared from England. And slowly we came to realize that when you deliver healthcare, it is not just a healthcare professionals, but it is mainly the community that needs to be part of delivering healthcare. Because we know health as a physical, psychological, and social well-being, and the psychosocial aspect is being given by the community. And hence, by 2000, a new era of palliative care started, which is known as the community palliative care system or the neighborhood network in palliative care, where every 14 houses, there must be one person who knows regarding what is palliative care and how the service delivery needs to be done. By 2008, Kerala became the first state to have a palliative care policy in the whole country. And the initial policy was to start off palliative care units. By 2019, we revised the whole policy in terms of structuring what is already there. So structuring the whole 1,400 government systems, 500 NGOs is what the 2019 policy that envisions, and we have made it into an action plan back in 2023. So for everything to happen, we need, as we know, the present generation AI model needs to be there, integrated within the system. And as you can see, the whole care platform, which has a broad spectrum of AI tools that has been developed, is slowly getting into palliative care system as well. I re-invite Bodhi to just to enlighten regarding the AI features that have been capacitated into the care platform for palliative care.
So back when the Gen AI revolution started, we thought of like imagining what are the possibilities with which we'll be able to like integrate Gen AI into the healthcare platform. It was like a large ideations that we done with multiple peoples, multiple teams and companies, and understood like what all are the possibilities that we could possibly do. This is that when we had like ChatGPT 3.5 and then 3.5 turbo released. So early ideas were most on like generating like an assistant, like more of like a RAG mechanism where you input a lot of content and it'll be able to like give you answers in the local language. But it was very evident that that's gonna like slowly. I mean, it's very evident that it's gonna like phase out very fast. But with new models coming in, multilingual capabilities like just started coming in. When we started doing it, the AI like the GPT's generation was very slow. Like Indian language generation was super slow that the request would time out. So we had to do all the processing in English, and we had to use Google Translate to translate this thing back into our local languages for support. And then we moved on. We played around with vision into like digitizing the patient records, also like imaging of 5 para monitors to extract out data. But slowly, what we realized is what care needs is a copilot. That's when we struck a partnership with OpenAI in trying to figure out what will be like copilot looks like and what all will be the features that will be needed for a doctor or like a nurse or a palliative care assistant who's giving care. where they can like interact with the system in natural language and have like a very seamless experience. So if there's a patient and they have their own health records and there are events fired, so in healthcare, like if you look at the data spectrum, there is only two type of events. That one that is already occurred, that I measured BP or I measured a pulse, or then there are like things that are scheduled. That means I'm going to do a procedure or the medication has to be given. So we created an events architecture in a way we are able to like capture a lot of these events, and the LLMs with its capability to understand and a good recall will be able to like provide diagnosis and also help assist in providing care for this such toolings. So we thought beyond it. It's not just have to be like giving assistance. It can also do more. That's when we thought, why not like build a voice fill? So you would have seen voice notes today, but this is like a different version. Like voice notes help you take notes, but what we are trying to do is like, why just take notes? Fill out the entire form for us. If you go to the next slide, we created something called as scribe. So this is our first feature on the copilot that we are building. So the copilot will assist in imaging, will assist in having conversation, will assist in automatic form filling, it will assist in generating discharge summaries, creating text-based summaries, get up information and like dig deep into the patient's record and figure out particular insights, and also build alerts. The first feature mostly looks at, if you look at it, whenever a doctor wants to fill a form, he just have to open the app, click on the mic button, just speak to the system. AI will be able to understand what is in the form, and it will be able to like generate, convert the text with the Whisper APIs, take it back, use an LLM, process the inputs, and also automatically insert. So basically, this can technically work in any application around the world. So it doesn't have to be like a care specific thing. It's completely built as a plugin. And we also, for introducing this, we created a plugin architecture in a way people can choose what model they want to use underneath. Should it be GPT or Gemini or like any other open source model? Fundamentally helping out uh, with like a decentralized access. So anyone who wants to deploy, they'll be able to choose what model they want to use, what kind of infrastructure they want to run this on to optimize cost and stuff. So this is like a very early version of the tooling. This is running live in Kerala. And what we're gonna do is like use the 4.0 live transcription. And the beauty is that with the live transcriptions coming in with the 4.0 voice, the system will automatically understand what the doctor and patient is having the conversation on, and it will be able to prompt the doctor, you forgot to ask about the patient's allergies. The system can automatically show prompts to the doctor to say, these are done, check, you have completed all of this, you need to like ask these forms to like complete this form. It'll be like transforming the entire UI UX of care into like a completely seamless experience with just voice. This is one version that we are like completely experimenting for the next 6 months. In a sense, we'll have like a cares voice only mode for most of the forms, making it like very easy. So this is like a large pain. Dr. Athul can talk more about it, like how doctors are always complaining about. So whenever we build care and like integrate and talk to doctors, all of them are always complaining, you guys have a lot of fields, make this optional, make that optional, it's very hard to fill. So even if it's all drop downs and all optimized for doctors, like just tap and go, all of them had this inhuman incubation on like filling these forms. Now we're just taking it all away. Eventually it can also be devices that the doctor will place on their desk that'll automatically capture this description and then show it on doctor's screen. He can edit it and click confirm and will be able to fill it. The next video, I have a short clip on how this is getting used in palliative care in Kerala. It's a video. Can we play it with voice? So what happens is it takes the audio, converts it, uses a LLM to convert it into structured data, and let the React page know that okay, this is the data coming. Automatically fill it for the doctor. He can also check it out and verify it. We can skip the part. So going back to the next slide. So the features, like the possibilities of AI coming into healthcare is like limitless. It can build a lot of things. EMRs with structured data can like be used by LLMs to generate insights, create notifications, let even alert people. So real-time monitors, monitoring of patients. So any 5 para monitor sending in data along with the patient's customized profile. So basically all the medical history, they'll be able to generate dynamic alerts. So the nurse doesn't have to go in and configure on the device what is the point where they need to send beeps. So based on the condition, the systems will be automatically able to generate these alerts. And with LLMs becoming so fast, and like a lot of local LLMs, like locally runnable LLMs coming in, we feel that the push towards a copilot and AI integration into devices are gonna like take a large play in democratizing and making healthcare accessible to all. Back to you, Dr. Atul.
I invite Sanjay on showcasing us how we'll be going forward with this.
Hello. Hey, ഇതിനകത്ത് ഇനി ആ കൂടെ ഒരു 3 സ്ലൈഡും കൂടെ ഉള്ളൂ. I hope all of you understand Malayalam. Anybody doesn't understand Malayalam? Illa. Okay. So what is happening is, like Bodhi and Dr. Athul is saying, right? നമ്മളൊരു 85% ആൾക്കാരും മരിക്കുന്നതിന് മുമ്പ് ബെഡിൽ കിടന്നാ മരിക്കാൻ പോണേ. And either we or one of the family members we know will need a palliative care system. This system has been built in the state over the last 30 years. 30 കൊല്ലമായിട്ട് സംസ്ഥാന സർക്കാരും NGOസും കൂടെ ആയിട്ട് ഈ സിസ്റ്റം ബിൽഡ് ചെയ്തിട്ടുണ്ട്. And this covers all the 1,000 panchayats in our state. ഒരു മാസം 2.5 ലക്ഷം പേരാണ് വീട്ടില് ഇന്ന് കിടപ്പ് രോഗികളായിട്ടുള്ളത്. ഇവര് മരണം വരെ ഇനി എണീക്കില്ല. So care has to go to their home. Right? അവിടെയാണ് the partnership with OpenAI is coming into use, where we are able to build these tools which will help the nurses on the field and the doctors on the field provide just because Anup is here, right? Just for you remember Arjun from Profoundus. So I used to run this incubator called Startup Village many years back, and Arjun was one of the young college graduates who was working in a software company. Left his job and then came and built a company. Sold it for around 300 crores. Built another company in the US. Exited it. Was working in a large Nasdaq listed company. And Arjun ippam, big story short, 9 മാസം മുന്നേ ഒരു AI company തുടങ്ങി. Is hiring in Kerala, and he's raised $20 million. Okay. So his existing investors gave 5 million, and Arjun പറഞ്ഞു എടാ ഞാൻ വെറുതെ ബേരിയിലായിരുന്നുണ്ട് 2 ഫണ്ടിൽ കയറി. Okay. By the time you end the conversation and get out, the fund is saying എടാ ഒരു $15 million എടുത്തോ. Okay, it's solid $15 million is approximately 120 crores. It's an hour of conversation. Now the company has maybe a revenue of around 75 lakhs, $100,000. ഞാൻ ചോദിച്ചു എടാ വാല്യൂഷൻ എത്രയാ? $70 million. Okay, which is 560 crores. Right? So I asked him, എടാ ലോജിക് എന്താ? അപ്പൊ അർജുൻ പറയുന്നത് സിമ്പിളാ. എടാ നമ്മുടെ നാട്ടിൽ ഇപ്പോഴും ഈ സാധനം എത്തിയിട്ടില്ല. Okay, in the US, the fund is sitting with $1.5 billion. Okay, ഇപ്പൊ ഫണ്ടിന്റെ കയ്യിൽ തന്നെ ഒരു 10,000 കോടി ഇരിപ്പുണ്ട്. അപ്പൊ മിനിമം ഒരു 100-200 കോടി ഓരോ കമ്പനിക്കും കൊടുത്തോണ്ടിരിക്കുക. I mean, you have to qualify a certain bar to walk into that office, which Arjun clearly has through his exploits that he's done before, right? But once you've proved yourself as an entrepreneur, you walk into that building, you meet a guy who's already convinced. ഇവൻ ഇനി കൺവിൻസ് ചെയ്യേണ്ട ആവശ്യമൊന്നുമില്ല, എടാ ഇത് വലിയ സാധനമാണ്, ഇപ്പം വരെ മാങ്ങാത്തുലിയാന്ന് പറയേണ്ട ആവശ്യമില്ല. അവർക്ക് ഓൾറെഡി കൺവിക്ഷനും കാശും വെച്ചിരിക്കുകയാണ്, കൊള്ളാവുന്ന ആരുണ്ട് ഇത് എടുത്ത് കൊടുക്കാനെന്ന് പറഞ്ഞിരിക്കുന്നതാണ്. റൈറ്റ്? ആൻഡ് ദെൻ ദ വാല്യുവേഷൻ നമ്പർ, ഇറ്റ്സ് വെരി സ്ട്രേറ്റ് ഫോർവേഡ്. അനൂപ് ഹീസ് സെയിങ്, എടാ ഇത് കയറി പോവാണെങ്കിൽ 560 ഒരു 20,000 കോടിയിലോട്ടാണ് പോകുന്നത്. അപ്പൊ 500-ലാണോ കയറിയത് 700-ലാണോ കയറിയത്, ഡസന്റ് മാറ്റർ. But the speed at which that transaction and that thing is happening, that's not happening after so many years in India and in specifically in Kerala, which is what this whole opportunity is truly about, right? You build one successful large implementation of an AI powered grid with the largest company in the planet on working on AI, which is OpenAI, right? Then the thing starts getting international attention. People will ask, എവിടെ ഈ രാജ്യം, കേരളം എവിടെയാണ് ഭൂമിയിൽ, എവിടെ എന്താ കുറെ പിള്ളേരുണ്ടല്ലോ, എങ്കിൽ പിന്നെ ഇവിടുത്തെ കമ്പനീസിലോട്ട് എന്തെങ്കിലും കാശ് ഇട്ട് കഴിഞ്ഞാലോ, റൈറ്റ്? ദാറ്റ് ഇസ് ഹൗ ദ ഹോൾ സ്റ്റാർട്ടപ്പ് എക്കോസിസ്റ്റം സ്റ്റാർട്ടഡ്. നൗ യു ആർ അറ്റ് ദ നെക്സ്റ്റ് ലെയർ വിത്ത് ദിസ് ഹോൾ AI thing coming at you, right? So one of the key things developer communities like FAYA, because people is also here, right, is to spread this word about this new fellowship that is coming, where the best 100 students from the state can come join a full stack developer program, learn coding, and then work on production environment to build the palliative care grid, which നമ്മൾ എല്ലാവരും അവസാനം കയറി പോകാൻ പോകുന്ന ഒരു ഗ്രിഡാ. Right? I am now 40. When I used to build companies, I was like 20s. And my mom and dad never understood ഞാൻ എന്തൊക്കെ പറയുന്ന കാര്യം. It was all about technology or something. അപ്പനിപ്പം ക്ലിയർ ആയിട്ട് അറിയാം, നീ ജീവിതത്തിൽ അവസാനം ഗുണമുള്ള ഒരു സാധനം ചെയ്യാൻ പാടുണ്ട്. അപ്പൻ 75 വയസ്സായി, റൈറ്റ്? സോ they clearly now understand, എടാ കൊള്ളാവുന്നൊരു സാധനം നീ ചെയ്യുന്നുണ്ട്. And there's a lot of people who need this, right? And this slide was built specifically only for Anup because they were told me you'll be there in the audience, right? So the so this thing is, Anup, you have a large platform, right? And you know the larger picture where the grid is the first grid in a 100-step journey. ആ ഫസ്റ്റ് സ്റ്റെപ്പ് എടുത്ത് നന്നായിട്ട് വെച്ചാൽ എല്ലാവർക്കും ഇത് നേരിട്ട് കാണാം. ഇനി ഒരു മാസം കൊണ്ട് 2.5 ലക്ഷം പേര് ഇതിനകത്തോട്ട് കയറും. 1500 നഴ്സുമാർ എല്ലാ ദിവസവും 6 പേര് വെച്ച് കാണുവാണ്. അതായത് ഒരു ദിവസം 9,000 എൻട്രീസ് will happen. What you saw in that palliative care video, നഴ്സിനെ വിളിക്കുന്നു, നഴ്സ് വീട്ടിൽ വരുന്നു, ഒരു ട്രീറ്റ്മെന്റ് നൽകുന്നു. പ്രായമായ എല്ലാവർക്കും ഈ ഒരു അവസ്ഥയിലോട്ട് കയറും. the same way we were born, അതുപോലെ ആയിരിക്കും നമ്മൾ എക്സിറ്റ് ചെയ്യുന്നത്. എല്ലാവരും ഫ്രെയിമിൽ നിന്ന് ഒരു ദിവസം ഇറങ്ങും. 40,000 ദിവസം മാക്സിമം ഇവിടെ ഉണ്ട്, റൈറ്റ്? സോ ഇൻ ദാറ്റ് ഫ്രെയിം, ഇഫ് യു ക്യാൻ മേക്ക് ദാറ്റ് എക്സിറ്റ് വെരി ബ്യൂട്ടിഫുൾ ഫോർ എവ്രി വൺ, ബിക്കോസ് യു വിൽ ഹാവ് ടു എക്സിറ്റ്, റൈറ്റ്? ആ ഒരു സാധനം വെച്ച് തുടങ്ങുവാണെങ്കിൽ, ഇഫ് യു ആർ എ പൊളിറ്റീഷ്യൻ ടുഡേ, യു വിൽ നൗ നോവെയർ ഗ്യാരണ്ടി ക്രിയേഷൻ ഓഫ് ജോബ്സ് ടു യൂത്ത്. നടക്കാൻ പോകുന്നില്ല. All the folks we are talking in the tech sector are clearly saying this thing is going to become super intelligent, right? And once it becomes super intelligent, കുറെ ജോലിയൊക്കെ അങ്ങ് പോകും. ഇപ്പൊ ഇനി ജോലി ഉണ്ടാക്കാം എന്ന് തന്നെ പറയുന്നതിന് പകരം ഈ ബുദ്ധിശക്തിനെ എടുത്തിട്ട് കുറെ പണി അങ്ങ് എടുപ്പിക്കുക. അതാവുമ്പോൾ നമ്മുടെ ജോലിയൊക്കെ അങ്ങ് കുറയും. അതാണ് നമ്മുടെ ഉദ്ദേശം. ആൻഡ് അതിന് കുറെ സെക്ടറിന് ട്രാൻസ്ഫോം ചെയ്യാൻ പറ്റും. കാര്യം ഇതിന് കാണാൻ പറ്റും, ചിന്തിക്കാൻ പറ്റും, കേൾക്കാൻ പറ്റും, എല്ലാ ഭാഷയും സംസാരിക്കാം. കേരളത്തിൽ ഉണ്ടാക്കിയ ലോകത്ത് എവിടെ ഈ സാധനം പോകും, റൈറ്റ്? That's the opportunity that is in front of us for doing a societal scale transformation. പക്ഷെ ആദ്യം ഒരു ഗ്രിഡ് കാണിക്കണം. സ്റ്റേറ്റ് ഡേറ്റാ സെൻട്രൽ സർവർ വന്നുകൊണ്ടിരിക്കുവാണ്. 4 മണിക്കൂറിന്റെ പണി 4 ആഴ്ചയായിട്ട് നടന്നുകൊണ്ടിരിക്കുവാണ്, റൈറ്റ്? ഒരു ദിവസം 2 ലക്ഷം രൂപയാണ് ബേൺ. So this is our shared future. There's absolutely no doubt of it. If you believe in medical science, either you will be part of the grid one day in future, or some of your family members will be part of this grid. So then let's build it together. It's an open source project. Thank you.
Thank you so much, team. We have a small memento also, inviting people.
Okay, all the best. Good events.
Next, we have Jibu alias Mozilla Responsible Computing Fellow. We have the keynote session on the topic Building Ethical AI Ecosystems, Challenges and Opportunities.